So what I'm going to talk about is just to give a brief introduction of kind of currently where we are or where we have been in the diagnosis of inborn errors of metabolism and the limitations of that testing that we have, particularly for undifferentiated phenotypes such as intellectual disability or non-syndromic seizures. And I'm going to just briefly talk about the methods that the company Metabolon, that's our collaborator in this effort, employs, go through the data that we have generated through the validation process of this. I'm going to talk about how we have been able to use metabolomic profiling to clarify variants of uncertain significance that we find on whole exome sequencing or other sorts of DNA testing, with some particular attention to neurometabolic phenotypes that you'll see where we've kind of been the most successful in making diagnoses. And then I'm going to finish up with kind of a little bit of a tangential story about how we can use this for new discovery and for understanding treatments that, the impact of treatments that we are giving to children with inborn errors of metabolism. So as Nina mentioned, we've kind of named this global MAPS, where MAP stands for Metabolomic Assisted Pathway Screening. And as I think most everybody knows, currently when we see a child with intellectual disability or seizures and we wonder if they might have an inborn error of metabolism as the underlying cause, there are a number of different tests that we often will do, such as a plasma amino acid analysis or urine organic acid analysis, sometimes other sorts of things like purines and pyrimidines or those sorts of things. But none of these have a very high positive rate in this sort of population of children with intellectual disability, but because many of these disorders are treatable, certainly I think many of us feel that it's important to test for them. But as you can see, there are a whole bunch of different tests, and we wind up often kind of ordering tests and we do them sequentially, but maybe it doesn't necessarily make a lot of sense even to do them sequentially, because honestly, if you look at these, there's probably no one that's a lot more common than another, particularly if someone has had a normal newborn screen. And so again, kind of the current challenges are when we're faced with these patients, how much workup do we do and how far do we go and how do we do it in an efficient manner that ensures that we've tested for things that are treatable or tested for things for which there might be a familial recurrence risk for family planning. Moreover, we often need various tissue types of blood and urine or CSF, and that can also be a challenge in getting those samples in children. And then again, the cost it starts to be a challenge as well with more and more testing that you do. And so when we started this collaboration with Metabolon, the idea is that, well, whole exome sequencing is great, but that's really kind of pretty far removed from the basic phenotype or the basic pathophysiology of what's going on. That if we can get to the biochemical analytes that are as close to the pathophysiology as we can, that this might be as informative for inborn errors of metabolism as whole exome sequencing is for genetic disorders in general. And again, it really is, as you'll see, can be a bridge between the genome and the phenome to help us better understand what's going on in an individual. So I know that the autism group here has collaborated with Metabolon on research projects in the past, and so many of you may be familiar with this. They are, I think, the global leader in metabolomic profiling and have pioneered biomarkers for diabetes mellitus and many other things, both in human and non-human research subjects, and they have this very large facility just across the border in North Carolina, where they have a lot of very smart people working for them and a lot of fantastically sensitive tandem mass spec machines. So the methodology that Metabolon employs to do this analysis involves tandem mass spectroscopy that's run in 3 different modes after ultra-high pressure liquid chromatography. They then take the results from this untargeted tandem mass spec platform pathway, search their library, a statistical analysis is performed, and then we get the raw data, and I'll show you some examples of that in order to generate an interpretation. And so this is just a great pathway slide that Metabolon likes to show. So if anybody wants to pick out their favorite molecule there, you're welcome to. But basically, I'll show you some other slides maybe subsequently that are zoomed in on this. But it is nice that they have all these analytes kind of mapped to one another, again, as you'll see, so that we can really kind of come up with a more comprehensive understanding of how perturbations in one pathway can influence other biochemical processes that are going on in an individual patient. So the data we get typically, they're screening for about 2,500 small molecules. So any large molecules like glycosaminoglycans or other sorts of things we're not detecting on this test. Because it is an untargeted test, we don't get an absolute value of a particular analyte, but rather what we can get is a z-score in comparison to a normative population. Again, kind of from the outset, what we had imagined was these sorts of undifferentiated phenotypes where we do a lot of biochemical testing, and potentially using this in combination with whole exome sequencing. Again, just to emphasize, any sort of large molecule we are not, Metabolon is not able to detect on this testing. There are certain analytes such as homocysteine where we're not able to detect that compound because a special extraction would be needed, although other related compounds to homocysteine are detected. Want to emphasize that it is a screening tool, and we never have a firm guarantee that a specific compound will be identified, although I think, as you'll see on subsequent slides from the validation assay particularly, we seem to be able to quite reliably identify abnormal analytes that we would expect to see in some novel analytes. And then, at least at this point, because of the turnaround time, it's not appropriate for acute assessments. And again, I'll emphasize this in the future. I think if you have a very specific diagnosis in mind, also, I think would go straight to a diagnostic test rather than this sort of screening test. So when we started this process, what we did is we opened up the freezer and pulled out a whole bunch of stored samples on individuals with known inborn errors of metabolism, as well as a series of normal controls. And I have this in quotes because these are individuals that we had done testing on in our lab for various things and had normal test results, although obviously if people are sending a sample to a biochemical genetics lab, they're probably not entirely normal. And we did try to age and sex match the control population. So this is on the right, a histogram showing the age distribution. So not surprisingly, the majority of the samples in the validation assay were coming from children, although we did have all the way out past 50 years of age. We included 200 samples from 128 different individuals, along with 72, again, in quotes, normal controls. Of the individuals with inborn errors of metabolism, there were 27 different inborn errors of metabolism. And I want to emphasize that the majority of the patients with inborn errors of metabolism were actually on treatment. And so I'm saying that because I want to emphasize that I want to show the limitation of that, but also that even on treatment, we were reliably able to identify various inborn errors of metabolism. So this is just a breakdown of the different categories. So you can see we had a smattering of all sorts of different inborn errors of metabolism, and I'll go through some specific diagnoses in a moment. In comparison to kind of what we detect in our biochemical lab presently on all the different assays we do, if we look at things like plasma amino acid analysis, urine acylcarnitine analysis, and various other sorts of analytes that we detect, like creatine guanidinoacetate or methylmalonic acid or those sorts of things on panels of tests for which we do quantitative assay. I'm not including organic acids in this because we don't quantitate those in our lab. But we measure and give a number specifically on all our testing for about 83 different analytes. In comparison to what we typically are seeing on the metabolomic detection with regard to ones we're getting a Z-score on, that is well over 450 human metabolites. And Metabolon also has on this a series of drug compounds, xenobiotics coming from bacterial metabolism, and other sorts of things. I may kind of take aside, you're going to see a couple of different numbers just to clarify with regard to the number of metabolites that Metabolon normally detects. The reason this number is smaller than other numbers that you will see is that these are the ones that get a Z-score. They do periodically detect rare metabolites that are generally so infrequently seen in the normal population that we can't really get a Z-score on that reliably, and so you will kind of see these different numbers, but that's why that is, so don't let me confuse you. And so in comparison, you can see that we detect the majority of metabolites that we're already screening for in our diagnostic lab on the metabolomic profiling. There are a small number that are not detected, but again, I want to kind of show you on subsequent slides how those are actually compensated for in some way by having many other metabolites in that pathway of interest that are detected. So just to kind of start with how did Metabolon do? So what we did is do an assay of precision to generate R values for quite a number of different compounds where we detected, and so basically our quantitative value got converted to a Z-score based on our mean and normal range, and then that was compared with the Z-score for that Metabolon provided us on the sample. And so you can see that this is phenylalanine. We did probably about 24 or so other metabolites generating the R value, and for almost all of them, we had a very tight correlation between the result that Metabolon provided us and what we did on our, plasma amino acid analysis or whatever quantitative testing that we were doing. The detection generally was very linear, and the vast majority of compounds seemed quite stable. As you might imagine, with the number of inborn errors metabolism, these all weren't samples from the last week or so. Some of them have been in the freezer for heaven knows how long, but in general it looked like all those things were quite stable. So I'm just going to kind of start, and again, I want to emphasize that the numbers that I'm going to be showing you are all Z-scores. And so on this, I'm just showing you individuals with PKU, and you can see the blue circles are the blue open circles are the normal controls, and the red solid circles are individuals with PKU. So you can see there's a very nice distinction between the normal population and individuals with PKU that we can reliably detect. And if we want to kind of expand this to other inborn errors of metabolism with just, again, kind of not all of them, but a few selected ones to get them on the slide. You can see that in general, between the affected population and the control population, there's a very nice distinction, again, majority of them even on treatment, between these individuals. Also, to emphasize that even though there are certain compounds that we maybe don't see, we're also seeing some new compounds, again, like homoarginine here in argininemia or other sorts of things that are really quite impressive. So this is, as promised, kind of an example of the phenylalanine pathway. And so you can see up here with regard to phenylalanine and tyrosine metabolism, phenylalanine, phenylpyruvate, and phenylacetate, all that are quite high. I should say that the red circles, on most of these, the red circles are going to be high levels, the blue circles are going to be low levels, and the diameter of the circle is proportional to the z-score. And then all these other things would be relatively normal z-scores. So you can see very significant z-scores here and kind of the impact on the whole pathway and the various metabolites that we're detecting. Just to kind of show, I'm going to kind of show you in a couple of different formats of how we can look at things. This is an individual with propionic acidemia. Metabolon has annotated the various metabolites based on pathway that you can see over on the right side of the slide. You can see in this individual with propionic acidemia on the heat map there that the energy category has a bunch of things that are particularly high that are mapping over to the red side of the heat map. And then when we break that out, you can see that there are things like we would expect to see, like methyl citrate and 3-hydroxypropionate in an individual with propionic acidemia, as well as related metabolites that all have z-scores greater than 3. And again, I'll show you on a subsequent slide, the proximate metabolite to the block, methylmalonyl carnitine, you can see has a low z-score, which nicely maps to the pathway and what we would expect. This is an example of methylmalonic acidemia. Again, we've got them broken down by category, but now we've kind of plotted the various metabolites as individual circles on this. In methylmalonic acidemia, you can see that the branched chain amino acid pathway is quite elevated, and that's corresponding to the methylmalonyl carnitine and propionyl carnitine. These are box and whisker plots of various compounds in various different disorders. So the first, on each of these squares here, the first box and whisker plot is going to be our kind of normal or control population. The second box and whisker plot is going to be other inborn errors of metabolism other than propionic, methylmalonic, and B12 disorders. The middle box and whisker plot is disorders of cobalamin, transport and biosynthesis, and then finally methylmalonic and propionic acidemia. And so you can see that the different pattern that comes up with these different disorders where 3-hydroxypropionate is not surprisingly highest in propionic acidemia, also quite high in methylmalonic acidemia here, and modestly elevated in cobalamin. Another example where methylmalonyl carnitine in propionic acidemia is actually below the control and other disorder population and quite high in MMA and high but not quite as high in MMA as cobalamin defects. We also, there are a number of compounds that Metabolon detects that they presently have not identified. So this is one area of interest for us and for Metabolon, I believe, as well. So again, it's the same set of disorders. So you can see that there are these 3 unidentified compounds that look like they have a very nice, clear signature for methylmalonic, propionic, and disorders of cobalamin transport and biosynthesis as well. This is yet another way we have fellows in the lab who we task with making all these lovely diagrams along with Metabolon. So this is a pathway of branched chain amino acid metabolism, of course, showing various different disorders. The green diamond is showing the block in maple syrup urine disease, the black diamond in isovaleric acidemia, the orange diamond in 3-MCC deficiency, purple diamond is HMG-CoA lyase, red is propionic acidemia, and the light blue and yellow is MMA and cobalamin defects. And you can see the various metabolites along these different nodes and the plots of these different disorders and how, again, in Z-score, and how these vary and are distinct one from another of the different disorders and allow us to see very specifically where the block is. Again, another interesting thing on a single test, we're able to see how a block in a particular pathway impacts other pathways. So these are a series of individuals with arginase deficiency, the block in the urea cycle shown there with the yellow star over on the right-hand side. And you can see that arginine is elevated as you would expect in the urea cycle. Ornithine and urea downstream from arginase have low Z-scores, but also over on the right, the impact on pyrimidine biosynthesis and degradation, as well as the nitric oxide pathway with very elevated levels of homocitrulline and homoarginine that, again, we're particularly interested in with regard to better understanding the pathophysiology of argininemia and why they get spastic diplegia and intellectual disability irrespective of level of hyperammonemia. So this is just a list of the disorders that we were able to reliably detect on the validation assay. And I'm not going to read them all, but again, various organic acidemias, urea cycle disorders, other amino acid disorders, and fatty acid oxidation disorders. So we had lots of discussions about how we were going to report the data. I would say I was quite concerned, given the number of metabolites that we were going to be getting back from Metabolon, of how in the world we were going to ever get through all of this data to generate a report. But it's actually quite surprising. In the vast majority of individuals, we actually don't have a whole lot of compounds, for the most part, that are really significantly outside the normal range. So we're able to get analytes that have a Z-score greater than or less than 2 standard deviations from the mean. We also get a categorization by pathway. And then what we have decided to provide in the lab is, and I will say that this has been met with enthusiasm in some quarters and too much information in other quarters. But basically, this is what we're doing. This is an example. I think I'll show you another slide or two about this in a little bit, of an individual with adenylosuccinate lyase deficiency. And so you can see the succinyladenosine here has a Z-score of 7.7. And then we get a couple of other things with modestly elevated Z-scores and a couple of other things with slightly low Z-scores, but really, given the number of analytes, I think for me at least, it seems like a relatively small table of things that are outside 2 standard deviations from the mean. And then, of course, we're asking for clinical information so that we can best interpret this test, particularly if people are on special diets or other things, since we do get a lot of lipids and fatty acids and other sorts of things that can be coming from diet. So I'm going to now move on to talk a bit about our experience with using this to try to validate variants of uncertain significance that we're finding on whole exome sequencing. These, as you're going to see, are mainly neurologic phenotypes, which is probably not terribly surprising. This is an example of citrate transporter deficiency. So you can see in the box at the upper left, whole exome sequencing was done first. There was a stop, and according to ACMG guidelines, mutation that would be variant that would be categorized as pathogenic. But then there was this other variant that, based upon most prediction models, this threonine to methionine, was not predicted to be pathogenic, but these were very rare variants that were not seen before. And so the phenotype is that of seizures and severe intellectual disability, so not anything that's obviously terribly specific and helpful with regard to kind of a rare phenotype. And so what we did was we took plasma from this individual, did the metabolomic profiling, and you can see over on the right the TCA cycle and the level of citrate that's 5 standard deviations from the mean and far above what had been seen in the control population and the samples that we had run to date. Also, you can see in the pathway over on the TCA cycle pathway over on the right, the blue circles where the things downstream, such as malate, fumarate, and alpha-ketoglutarate, are all low, and we've now found a couple of other individuals with citrate transporter deficiency, and actually one of my colleagues at Baylor, Brett Graham, is going to be looking at anaplerotic therapy with triheptanoin for this disorder to see if he can kind of jumpstart the TCA cycle and bypass this process. The next whole exome case that we looked at was from a 4-year-old with developmental delay and hypotonia. You can see a large number of biochemical testing, everything from very long chain fatty acids, lysosomal storage diseases, plasmaminos, urine organics, microarray, urine MPS, all the way to a muscle biopsy for mitochondrial enzymology. And other sorts of testing. Whole exome sequencing was done. Again, 2 variants of uncertain significance in trans, in the aromatic amino acid decarboxylase deficiency that, again, had not been seen before. Prediction programs gave conflicting information about pathogenicity. This is to kind of remind everybody of the pathway of AADC, where the block there prevents the generation of both dopamine from L-DOPA and serotonin from 5-hydroxytryptophan. And so what you would expect in this disorder is an elevated 3-methoxytyrosine, also known as 3-O-methyl-DOPA, and then low levels of HVA and 5-hydroxyindole acetic acid. And so when we did metabolomic profiling on this individual with the 2 variants of uncertain significance, you can see that the 3-methoxytyrosine, also known as 3-O-methyl-DOPA, had a z-score of about 6, and again, far beyond what we had seen in anyone else. Emphasizing the downstream pathway, typically able to detect HVA and 5-HIAA in some quantity in most individuals. In this individual, no homovinylic acid or 5-hydroxyindole acetic acid was detected. We also went on to confirm this with CSF analysis, and as you can see, the 3-O-methyl-DOPA was elevated at 427 nanomolar on the CSF neurotransmitter analysis. The next case is a case of Gaba transaminase deficiency, also called ABAT. This was a 19-month-old, again with developmental delay, hypotonia, some abnormal movements, had normal typical testing, including normal CSF neurotransmitters, although the panel that was done by the probably the busiest reference lab for the CSF neurotransmitters did not measure Gaba. Whole exome sequencing was done, and the ABAT gene, again, 2 variants of uncertain significance in trans that are shown here. And again, on the left, showing you the pathway here where a block in Gaba transaminase prevents the conversion of Gaba to succinic semialdehyde. And what we see is rather than Gaba, the related metabolite that's in equilibrium with Gaba, 2-pyridinoline, that is greater than 6 standard deviations from the mean in this individual with Gaba transaminase deficiency, and again, far from what is normal. And then I think the last case of whole exome to metabolome that I'm going to talk about is the adenylosuccinate lyase deficiency case that I'd shown you on the sample report. So 24 months old that was been seen in the neurology clinic for global developmental delay with no seizures and had had an EEG as well that was in normal limits for age. Had had, as you can see, quite a number of testing to date, including MRI, standard metabolic things, as well as CSF and CSF neurotransmitters. Metabolomic profiling revealed the very high succinyl adenosine level, and then we went on to obtain a urine sample for confirmation, and those levels are shown in the bottom right. You can see very significant elevations in urine succinyl adenosine. I'm going to move on just to talk about a couple of other uses that we've tried out for this. So one of the medical biochemical genetics fellows looked at metabolomic profiling for VL-CAD versus fasting. Our endocrinology group frequently admits patients to the hospital for a controlled fast in order to assess for hypoglycemia, and they always want to order an acylcarnitine profile at the time of hypoglycemia or the fast. And what we typically see are these sorts of modest elevations in long-chain acylcarnitines, as are shown on these two reports from our lab here. We often don't get a lot of clinical information. Sometimes we try to go into the chart and see, but sometimes it's not from our institution. And so we always struggle with how to report this. When we're looking at it, we think it looks probably like somebody that's been fasted, but we never really know for sure exactly what's going on. So you always worry we're kind of dismissing something that could be maybe a mild VL-CAD deficiency. And so what Lindsay looked at was taking these sorts of samples from fasted patients with these modest elevations in long-chain acylcarnitines, and kind of looking and seeing what the metabolomic profiling looked like. So this is the data of the acylcarnitines and the glucose, and you can see that certainly indeed, as we see on the acylcarnitine profile, the tetradecanoyl carnitine is elevated with a z-score of 3. But then when we look at all the other data that we're getting from metabolomic profile, including the free fatty acids and ketones, you can see in comparison to a patient with VL-CAD deficiency versus someone who is fasted, there's quite a clear difference with the fasted individual having very high levels of the long-chain free fatty acids as well as ketones in comparison to the individual with VL-CAD who has normal levels of those regular free fatty acids and ketones. So maybe in the last kind of 15 minutes or so, and we'll have a little time for discussion here at the end, I'm going to kind of talk about a project that our recent clinical biochemical genetics fellow, Marcus Miller, has looked into. Just to give you a little bit of background, there was a publication in the New England Journal of Medicine in Nature Medicine in 2013, looking at carnitine metabolite called trimethylamine N-Oxide in atherosclerosis. The way that the place that trimethylamine N-Oxide comes from is first we consume carnitine in our diet that's mainly coming from meat in the intestine. That gets broken down and absorbed in, metabolized by bacteria in our gut to trimethylamine. That trimethylamine gets absorbed into our bloodstream and our liver converts it to trimethylamine N-Oxide. That suppresses bile acid biosynthesis and has been shown to be associated with increased risk for atherosclerosis. And so what the paper did in looking for this, and again, this is normal individuals, we've left the inborn errors of metabolism for a moment, but we'll come back to them. So they looked at individuals who were vegan or vegetarian versus people who were omnivores and measured their level of trimethylamine N-Oxide. And so you can see people that were eating meat had higher levels of TMAO. They then took the baseline levels, they then took these two groups, gave them deuterated carnitine and then looked at the production of TMAO, and you can see on the line at the bottom with the triangles that when you give someone who's a vegan or a vegetarian a high level of carnitine, they do not make much trimethylamine N-Oxide at all. There's only a very slight increase. Whereas with the omnivores who've been eating meat, when you give them this, they get this big surge in trimethylamine N-Oxide when they consume carnitine. And so obviously this generated a lot of concern, particularly in various groups like the Organic Acidemia Association and other sorts of things, and children that we're giving high levels of carnitine to, and what are we doing to them, and are we increasing their risk of atherosclerosis? And so I think there was a lot of discussion on Metabel, the metabolic list server, that, well, you need to look that, most of those kids with organic acidemias, they are on a vegan or vegetarian diet, and even though they're getting a lot of carnitine, that's probably okay, because if you look, it's only in the vegans or vegetarians that they're making a lot of trimethylamine N-Oxide. But we wanted to kind of take a look at that and see if indeed that was the case. And so first what we looked at were the plasma samples that we had sent for validation, and just to look and see if the metabolomic profiling identified trimethylamine N-Oxide. And so the first circle at the top is individuals that were, again, kind of no diagnosis or the normal control, and you can see about 2/3 we were able to identify trimethylamine N-Oxide, and about 1/3 we were not. Whereas in individuals with organic acidemias, and I'll show you some data in general, all these individuals were on carnitine. You can see that out of 24, there was only one where we did not identify trimethylamine N-Oxide. This is a box and whisker plot of the Z-score of TMAO. On the left, with the red box and whisker plot, you see the individuals with organic acidemias who have significantly higher levels of TMAO as compared to individuals with no diagnosis. One of the clinical residents went through all the charts of these patients, and again, 19 of them were local that we were able to get good, reliable data on. All of those where we could, all of those 19 were on chronic oral carnitine supplementation, and as you can see, there was a very wide range in the dose, but all of these would be kind of relatively high for someone kind of not on carnitine supplementation and just getting carnitine from diet. Reviewed the chart, and all were highly discouraged from consuming meat. As you might imagine with organic acidemias, and I'll also show you some metabolomic data that we looked at to see if we could tell if indeed that was the case, and this is it. So 3-methylhistidine is a non-human metabolite that comes from our diet, And you can see that in both in individuals with kind of no diagnosis who presumably are consuming a normal or omnivore diet, that they are having an average Z-score of 0, and individuals with organic acidemias have similar scores to individuals with urea cycle disorders or PKU, supporting the idea that indeed these individuals are not surreptitiously consuming a whole bunch of meat. When we looked at plasma carnitine levels, interestingly, in the individuals with no diagnosis, they actually had higher carnitine levels than the individuals with organic acidemias, all of whom were supplemented. When we looked at the carnitine level in comparison to the trimethylamine N-Oxide level, you can see this inverse correlation in that the higher the TMAO level, the lower the carnitine would be. And all of these levels, as you can see, are reaching statistical significance. So what we are concerned is going on here, and we're pursuing this further, is that in individuals with organic acidemias, even though they're not consuming meat, because they are on chronic carnitine therapy, they're developing an intestinal microbiome that very efficiently chews up all that carnitine that we're giving them, converts it to trimethylamine, and so they're not getting very high levels of carnitine in their bloodstream. Instead, they're just getting high levels of TMAO. And so, again, we're in the process of trying to look at this further, but we are concerned that our preliminary data is showing that maybe carnitine supplementation for organic acidemias isn't really doing quite what we think it might be doing, at least chronic carnitine supplementation. So in summary, just for the validation assay, we were able to identify various common inborn errors of metabolism that we have studied to date. This is a screening tool in the first 300 or so samples that we have done clinically. When we look at again, most of them are coming in for phenotypes of developmental delay, intellectual disability, seizures, as well as some things like poor growth and hypotonia. In the developmental delay and seizure group, we are having an 11 to 13% diagnosis rate in that group. Limitations are that due to turnaround time, as well as other sorts of things, I think we're not saying that these are going to replace other sorts of diagnostic testing when you have a very specific disorder in mind, or if it's an individual who's acutely ill. We're not able to detect large molecules, so that's one of the things that we're kind of talking about now is for things like the various mucopolysaccharidoses or congenital disorders of glycosylation. Is there some way we can kind of fill in that gap that we have an even more comprehensive test? I've shown that we've been able to identify various biomarkers such as citric acid, sorry, I've got a typo there, where in citrate transporter deficiency, presently there is no analyte or biochemical test you can order for citrate transporter deficiency, but we certainly can see that on the metabolomic profiling. The utility in using this to try to confirm variants of uncertain significance that we are finding, as I'm sure everyone is, on whole exome sequencing. The ability to diagnose neurotransmitter disorders on a plasma sample. So most of the time for these sorts of neurotransmitter disorders like Gaba transaminase or ABAT deficiency, you really need a CSF sample to make that diagnosis. And we've been able to see abnormal metabolites even in plasma of those individuals. And then again, this ability to use it in new discoveries, since we do get so much more data about what's going on and how various treatments that we're giving patients with inborn errors of metabolism impact other physiologic processes in their body. So I want to thank first Metabolon for their collaboration and Adam for being here, as well as my co-lab directors and various residents and fellows in our program that have contributed to this data. So I want to thank everyone for their attention, and I'm happy to take any questions.
So, Reid, very interesting presentation. So if I understood correctly, the patients that are being treated, you're still able to see a difference. So, two parts. One, does that mean the treatment's not really doing what you thought it was doing in terms of alleviating the condition because you're not normalizing the value? And second, even if you're seeing a difference, is that difference is there a lower differential between those patients with treatment and those without? Because it would seem like you're not normalizing, and therefore the treatment really may not be as effective as one is hoping.
Yeah, certainly I think we know from the kind of regular diagnostic testing like we do, like plasma aminos or urine organics, that even for, let's say, citrullinemia on treatment or propionic acidemia on treatment, they're still going to have elevated levels of citrulline, and we kind of know that. I think the Metabolon's platform is a lot more sensitive than what we kind of do as a standard measure. I think this is one of the things that we're interested in, is seeing, again, even though kind of things like citrulline don't change or those sorts of things, are there other things that we can see that help us to better understand what we do with treatment? I didn't show, there's an example, one of the arginase patients that I showed kind of the arginines, the slide on in the middle of the talk. There was one of those arginase patients who had recurrent hospitalizations for hyperammonemia, which is relatively uncommon for arginase deficiency. That individual actually looked biochemically different than the other individuals in that individual had much higher levels in that kind of homocitrulline, homoarginine nitric oxide pathway, and much higher levels in the pyrimidine pathway. And so again, this is one of the things, it's one of the things we don't really know. Is it higher because he's worse? Is it higher because that's part of the pathophysiology and why he's hyperammonemic and the other ones are not? But I think that there is the potential for us to try to work out these sorts of questions with regard to treatments and what are we doing, and maybe even more kind of customizing or tailoring treatments based upon kind of what we see that we're doing or what's going on in these related pathways.
You've thrown this testing at things like Fragile X or Rett syndrome, which may not have good markers, and then in that condition or any other, how about the unknown compounds? If I can find an unknown that has a Z-score of, say, 7, do you follow that up to think of a possible model? Yeah,
so one of the exciting things about this test is the number of questions it generates. So I think your question is great about these sorts of things. So this is one of the things that we're kind of trying to think about as well, is are there disorders where we don't have a biochemical test where maybe we could see if there's a biochemical marker. So the list is so long. I think your suggestion is great to see, particularly in things like maybe Rett syndrome. Like, are we seeing perturbations based upon methylation problems and gene expression problems that are very specific? We've not looked at that. I think that's very interesting. One of the things we are kind of thinking about trying to start with something like Fabry disease, where there's not really a good biomarker presently to kind of screen for Fabry disease, or again, lots of the times, in the molecular lab, they're doing testing, and again, it's a variant of uncertain significance, and it's a male, and and of course the mother's got it, but you can't test other family members, and how do you interpret that? So I think that's one of the things we're certainly very interested in, is looking at all sorts of different things where we presently don't have a good biomarker to see if we can identify a biomarker, both kind of diagnostically and even potentially therapeutically. I think that it's a very interesting question. With regard to these undiagnosed compounds, that is something, again, that's kind of on our list. I don't know if Adam wants to comment, but Metabolon, certainly it's work for them. They can identify those compounds, but again, it's kind of this great long list of things that we want to do, and how do we prioritize those sorts of things. But I think certainly, particularly for a research basis, that's something that Metabolon has been very helpful and willing to work with us on, is these what they call X compounds, which are basically unknown compounds of what are they? Because again, as you could see for methylmalonic, propionic, and cobalamin, there are these other things that we're not quite sure what they are, that are clearly very abnormal and have a very clear and distinct signature in each of those disorders, one from another. Now comes the hard question.
Reid, thank you so much for that presentation. This is a simple one. Have you approached this from blood spots? This is so important that it looks like it should have worldwide distribution, and probably the only way to get at that is with dry spot.
Yeah, so we're presently validating that. Again, Metabolon has been very generous in working with us on that. I think we certainly agree with you that it would be nice to be able to do this on a dried blood spot for analysis, both for ease of analysis as well as just kind of consistency. But that's absolutely something that we're working on as well.
Just as a follow-up maybe to that question, given the applicability, my question is sort of a chicken and the egg thing. It may be way too early to tell, but do you think this will have sort of more applicability in the future to certain patient populations, so that you would do this before you did an exome, for example, and you went sort of the other way around?
I think, yeah, so that's a very good question. I mean, I think that certainly the cost of this is much lower than whole exome sequencing. I guess I kind of approach things maybe in a way that sometimes is a little different than other people. I mean, when I'm kind of seeing one of these undifferentiated phenotypes, obviously it's important to make a diagnosis so we know what we're doing, but for the vast majority of things that are treatable, it's these inborn errors of metabolism. And so I think in general, I'm kind of would be more likely to at least try this first, given the cost and given the treatment implications, as compared to whole exome, that's a lot more expensive and generally has a lot longer turnaround time. I would say just kind of from a very basic practical standpoint. So our experience is that because these are, now we're talking vulgar money, so if people don't like to talk money, you can close your ears. But, we have the problem, at least at our institution, for when we see patients, if it's a genetic test, almost all the insurance companies now, we have to get prior authorization, so then we can't do testing on the day, and we have to come back and all this sort of business. Because we're using biochemical CPT codes, those don't look like DNA or genetic CPT codes to the insurance. So we have not been getting prior authorization for patients that we're doing clinical testing on, and as far as we know, it's getting paid. We've not heard from the hospital or patients, which I'm sure we would have, that they're not paying. So that's also something that, again, just from a practical sort of standpoint, it's easier because like a plasma amino acid or urine organic, we don't have to get prior authorization for those. We just send it, and the insurance covers it because of the CPT codes don't look genetic.
So the Metabolon's data is based on a Z-score. So that means you need a reference. So reference cohort. So in your, for a new disease or new experience, how much, or what is what is the number you're looking for reference cohort?
That's a great question. So let me say that kind of one of the challenges, so we worried when we started this, honestly, that we didn't have a huge number of real kind of normal controls. Again, as I'd shown in the validation assay, we did kind of age and sex match all the theoretically normal controls that we were sending them. And again, this, like, we were quite worried, though, that it's still a relatively small number, and how do we do that? One of the things, again, that we're working on is really trying to get a good normal control population at various age groups. It doesn't, I will have to say, overall it doesn't look like it maybe makes that big a difference, at least from a diagnostic standpoint, that even, we don't have a huge number of normal controls for all the age groups, that, kids or adults who have disease, they really look distinctly abnormal from everybody else. But I think for kind of these sorts of finer tuning sorts of things about understanding treatments or understanding variations in phenotypes, why is it you have one kid in a family who has, lots of problems with their inborn error of metabolism, and another kid in the family who seems to do pretty well. I think the challenges maybe right now are that we don't have a large number of real normal controls. Again, this is something that we're working on with Metabolon to try to collect. As you might imagine, it's not super easy to get, 50 kids under 2 years of age who really are normal. But that, again, is something that we're working on and have started to kind of try to collect those samples so that we can get real normative populations based on age and sex. But it's a challenge. Other questions?
You kind of hinted at this, but can you just share how has your diagnostic approach changed? So have you replaced the class amino acids and organic acids, or where is this in your diagnostic?
I think for my practice pattern, again, if it's really somebody that I've got, a high suspicion of disease, an inborn error metabolism, I'm going to send the specific diagnostic test. If it's, a 4-year-old with non-syndromic intellectual disability, so that sort of patient where, lots of times we do plasminos and urine organics just because we don't want to miss something treatable. Those are the individuals for whom I'm now kind of ordering this test as opposed to plasma aminos and urine organics. I want to thank everybody for their attention. Thanks for the invitation.